Hello, Kananara, have you just joined us? Yeah. Hello? Yes, that's great. Well, so welcome. We'll be starting in about 2 minutes. If you wouldn't mind putting your microphone on mute, and at the end maybe just ask questions. Thank you. And Christmas Island has just joined us as well. Yes, is that Christmas Island? Okay. Fantastic. We'll be starting in about 2 minutes' time. If you wouldn't mind putting your mic on mute until the question time at the end. Thank you. Yeah. Hi, Bunbury. If you could just turn your microphone on to mute, please. Thank you. There's no one there. They might come in and out as you go, but they're easy. They're actually good, good users. In other words, they're so much more. Yeah, they're okay. Yeah, used to doing this than probably we are. To be honest. Yeah. There we go. Okay. Welcome everybody to the Maternity Care Providers video conference. I'm Jenny Owen, one of the midwifery educators. I'd just like to hand you over to Terry Barrett, who's the head of SOSU. Have a quick word. Hi ladies, it's nice to see you all here. So we can see Big Roy, Bruce, see people in Kununurra settling, Bentley, Christmas Island, hi Steve, Bunbury, Armadale, I'm not sure, Geraldton, and then we've got one more person that might be Bunbury, I think.
So thank you all for joining us. First session for the 2018 series, which is fantastic. Hoping that you can all hear. Hoping that you'll all have your mute button on unless you're wishing for us to hear what you're talking about. I would like just to introduce to you Dr. Chris Griffin. Chris is going to be acting in the Medical Director Statewide Obstetric Support Unit role for the next 3 months. Those of you in the country will know that Dr. Diane Moen's gone on well-deserved long service leave. So Chris is going to be joining us for the next 3 months, so you might see him or speak to him, and we're hoping to get out and about a little bit. So that's the face. Lovely Welsh accent. So we've got a really good session for you today. Today's session is by Rosalind Giglia. Rosalind has done a lot of work around the breastfeeding area, which is dear to all midwives' hearts, but she's also done a lot of work across the FASD area as well. I will just let you know that SOSU is close to finalising the FASD Audit C e-learning education package. So we're just having that tidied and tarted, and then it will be available on the SOSU website for you to use. So it takes you through how to use the Audit C tools and lots of resources to take you off to get some skills around brief interventions. I'll just pause to see if anybody had any questions or was wanting to know anything in relation to SOSU before I hand the floor over to Ros. Nobody's reaching for their mute button. So, great pleasure to introduce Rosalind, who's going to present to you now.
Hi everyone. I can't stay in the frame, which I'm not sure is a good or a bad thing, but for me it's a good thing. So I'm going to talk to the slides and sit out of frame, and then we'll finish up at around 2:20. Does that sound about right? Because you get an hour or earlier, and then we'll have time for questions. So I'm going to get started and questions at the end. Okay, so my presentation is about FASD. I'm going to give you a bit of background to FASD and also about using the Audit C. So I work for the Telethon Kids Institute. I'm the team lead of the Alcohol and Pregnancy and Fetal Alcohol Spectrum Disorder Research team. As Terry said, I'm actually a breastfeeding researcher as well, and at the end I do a bit of a plug on breastfeeding because I can't help myself. So we work across many different settings and groups. Our aim is to reduce alcohol consumption during pregnancy because FASD is 100% preventable. We hope to improve the clinical diagnosis of FASD, and that's an area that's really emerging. I know in the north of the state there's a lot of activity happening around that. And we're also looking at management and supporting families, parents and carers in the management of children with FASD as well. So we work across families, communities, health, education. We've done a lot of work in the justice system tomorrow. Watch the papers and listen to the radio and the news because we're just releasing our study in the Banksia Hill Detention Centre, and Professor Carol Bauer will be speaking to the, well, she's been speaking to the media all morning because that paper is going to be available online on BMJ Open tomorrow morning. It's been embargoed up until then. Working with policymakers, government and non-government, service providers and politicians. There's a very big interest at the moment in FASD, and so we're really trying to capture that audience while the pollies are interested. And I must say that the Minister for Health, Roger Cook, is incredibly interested in FASD. Unfortunately, it's not just a health problem, it's across education and justice, so bringing those other ministers together isn't always easy. So what is fetal alcohol spectrum disorder? And I'm just going to refer to it as FASD from here on in. And where do midwives fit into the cycle of prevention and support? Well, actually, you're integral to the cycle of prevention and support. So FASD is 100% preventable. If women abstain from alcohol during pregnancy, there is no reason to have a child born with FASD. So it's 100% preventable, but unfortunately it's not 100% curable. And what alcohol does, it disrupts the brain development and also that of other organs, and it causes lifelong problems. So the diagnosis of FASD is often alongside other conditions such as ADHD and autism. They may have trauma-related issues as well, and have their own alcohol and drug use problems. So it's a very difficult disorder to diagnose, and is quite extensive, and I'll talk about the diagnosis of FASD later. So this slide, and you'll be able to have a copy of the slides after the presentation, shows that alcohol, basically any alcohol can cause damage across the whole developmental stage of pregnancy. So throughout gestation, there is the possibility that alcohol will cause damage to the developing fetus. So often we get asked, oh, surely it's just in the early stage or only in the first trimester. Well, no, it's actually throughout, and that's why the NHMRC guideline is no drinking during alcohol during pregnancy is the safest option, because we don't know the lower limit of consumption that is safe, and we can't run a trial because it's unethical. So we really have to go with the evidence base, and that is that alcohol causes damage, so any alcohol can cause damage. FASD can result in a lot of problems, and they're neurocognitive problems across the 10 domains of development. So the primary disabilities are memory and learning deficits, attention problems. The children with FASD have difficulty in abstract thinking, so they can't work out maths. They have difficulty with money. If you tell them to rock up to an appointment at 2 o'clock, they don't really understand when 2 o'clock is. So they have difficulty processing and storing and retrieving information. So if you tell them that sport is on a Monday, they won't remember that next week. So it's a very disorganised brain. They're not very good at making decisions. Often they'll be impulsive in their actions, hyperactivity, and easily distracted. They take longer to process things, so I have a slower auditory pace. They can become quite agitated and irritable and prone to aggression very easily. We have fluorescent lights in here. They're the sort of things that might cause that agitation. They have an inability to understand cause and effect, so that's particularly relating to consequences. So if you hit the puppy will bite you, and then they'll do it again because the cause and effect doesn't actually make sense. Difficulty understanding social expectations and personal space. So they're what we call primary disabilities, and they often end up relating to, or ending up in, resulting in, I should say, secondary effects such as trouble with the law, trouble at school, often it's the naughty child, mental illness, reduced self-esteem, substance abuse, unemployment, homelessness, lack of education, inappropriate sexual behaviour. And I'll tell you a bit about our Banksia study and how that's very relative to these primary disabilities if I get time at the end. So there's your average brain, nicely organised, and there's a FASD brain. It's just all over the place all of the time. So this is, sorry, again, I apologise because I didn't realise that you weren't going to be getting the slides. But at all developmental stages, early years, childhood, adolescence and adulthood, FASD impairments will affect the life course. So I'm not going to read through those because I think that it's probably just too small for everyone to see, but just be aware that as early years in childhood, particularly that early irritability, sleep and feeding, which is important in infants in developing, then going to school as a young child and adolescence, and then as an adult, problems with mental health. So FASD is a diagnosis that requires certain aspects to be covered, and Professor Carol Bauer, who's been a stalwart in this area of research since the duration, wrote a really good brief communication in the Journal of Paediatrics and Child Health 2017, volume 53, and it really gave a great flow chart on the diagnosis of fetal alcohol spectrum disorder. And so if you want to know more about it, that's a great article. So it was the Journal of Pediatrics and Child Health, 2017, volume 53. But basically, what is looked for is confirmed or unconfirmed alcohol intake. Now, this is in a diagnosis where we have the presence of 3 sentinel facial features. I'll just check if this has got a pointer on it. Not quite sure. Anyway, so just remember, alcohol can be confirmed or unconfirmed when there is the presence of 3 sentinel facial features, and I'll go through what they are, and then with the neurodevelopmental impairments in 3 or more domains. So the facial features are the palpable fissures, the short eye openings, so short of between here, the smooth philtrum, which is the area between the lip and the nose, and then the thin upper lip. So the thing to remember is that 80% of children don't have these facial features, so you won't actually able to diagnose on just seeing a child. They will need to have much more specialist diagnostic assessment. So if the child, which is most probably the case, doesn't have the sentinel facial features, then to have a diagnosis, the alcohol exposure prenatally actually has to be confirmed. And I guess this is where midwives are key to a diagnosis when a child is of age to have a diagnostic assessment. And then they can have 0, so that's nil, 1 or 2 sentinel facial features, and then they still need the neurodevelopmental impairments in 3 or more domains. So there is a difference in what is required, but it's important if they don't have the sentinel facial features, which most children won't, that there is the confirmation of alcohol intake. So I'll just let you settle with that and make a note if anyone's got any questions for later on that. You can't just use intellectual disability or IQ as a indicator of FASD, because often children will fall in a range that is considered normal or just below normal or average. So it's not necessarily a great indicator. So as I said before, in the 2009 NHMRC guidelines, and I'll just let you know that these guidelines are currently under review and available, open to comment. There was a guideline for pregnancy and breastfeeding with regards to alcohol, and it was really around educating women about this and who's educating when and how. So these are the guidelines, and for women who are pregnant or planning a pregnancy, so that's actually in the lead up to falling pregnant, because often there's considerable alcohol intake during the period between confirmation of pregnancy and planning a pregnancy, and often that's when binge drinking occurs as well. And so not drinking is the safest option, and for women who are breastfeeding, not drinking is the safest option. Now, I wrote the guide for the breastfeeding women, and there's additional information associated with that you can find on the website, which talks about timing as well. So it's not a blanket of abstinence for breastfeeding women, but it's about timing. But for women who are pregnant or planning a pregnancy, then it is abstinence. So what are women saying about community perception of alcohol? I'm sure you all have your own perceptions about alcohol, and at the Institute we find if you drink you have an opinion, and that's fine, but really it's about what's the evidence base. So where I met with a room full of obstetricians at the end of last year, and when they announced I was from the alcohol and pregnancy team, they asked me not to tell them that their women couldn't drink, and I said, no, that's not what I'm here for, but I'll come back next time and I can talk about that. So everybody has an opinion, but we really need to stick to the party line, and the party line is not drinking during pregnancy is the safest option. So in Australia, it's just our society in general, it's so based around alcohol. Everything we do, that's why it's such a big deal, and we talk about it, dealing with it all the time. When you're in early pregnancy, that's the hardest thing sometimes not to tell people that you are pregnant, because there is no excuse otherwise for why you are not saying yes to a drink. So I'm not going to read them all, but it's basically what these quotes tell us is that there's a lot of social pressure, and then the last quote says there's actually, she finds the message confusing because different opinions from different people, and that's why as health professionals we all need to be sticking to the NHMRC guidelines. I'm not sure if anyone ever gets online to these bub hubs or pregnancy mum blogs, but there's a lot of other information out there. So what can midwives do to help in the prevention of FASD? So it's the A's: ask, assess and advise women during pregnancy. Brief intervention to support women are important to make the positive changes, and then assist with referral if you feel that the woman is at high risk alcohol intake. And that's not your subjective opinion, that's your informed opinion through the handheld pregnancy record, which contains the Audit C, which we'll talk about as well. And then community and family education and support is available. So we continue to have, what I would consider, given it's a 0 level, that's requested a high level of alcohol intake during pregnancy. So it's roughly around 20% drink at high, 7 to 20% drink at high risk levels. 57%, so that's over half, consume some alcohol during pregnancy, and 20% of regional women drink during pregnancy. And it's around 19% of women continue to drink once they actually know they're pregnant. So it's quite high in terms of that. We know that alcohol is a teratogen. So in the 2014 midwife survey, that was Dr. Jan Payne, in the survey 93% of midwives said they asked about alcohol and 99% advised no alcohol. But 93% of midwives wanted professional development, and I guess that's apparent today. I think we've got 18 sites that have come on board for this presentation, which is great. So this, you'll be familiar with this, this survey. This is in the handheld record. And this is the first question on about, I think it's page 3 or 2, and it's about alcohol and other drug use. What often happens here is, and I'll present some study findings from Dr. Tracy Wright-Bell in a minute, is that if there's a response to this question of no, the midwife doesn't actually go any further to fill in the Audit C, and that's what we need to change. So, and again, I'll show you going through the slides, qualitative research has shown that women actually really want to be interrogated. This first pass of just answering this question isn't what they want, and although they say no, once you ask them a little bit further, they will respond, and then that's the opportunity to talk about alcohol, and that's what you want. And really, as a midwife, you're asking so many questions about medications and tobacco. Alcohol is just another one on the list. So this is the Audit C, and again, it is actually a brief intervention tool, because once you've scored it, there is, and added up the scores, there is direction for advice. So this should be asked at least, asked pre-pregnancy if there's that opportunity. So, you would ask before pregnancy, did you drink alcohol? How often? Monthly or less? 2 to 4 times, 2 to 3 times, 4 times plus a week. Then how many standard drinks? And then how often do you have more, or five or more? And 5 or more is considered to be binging. And then it should be at another 3 times throughout pregnancy. As I said before, often it's not asked, or it's asked once, and if it's no, people don't tend to ask again. But if we're going to be looking at diagnosing a child, so when a child enters the school system, this is for the future, thinking about it, and they're having troubles with learning, and there's no reason, or we can't, the education assistant, the school psych can't consider why, there may be the request for the medical records during pregnancy, and if there's an accurate record, then that diagnosis will be able to be made. In our research, we never consider the stigma to the mother. It's all about moving forward. It's not about reflection. When we've had women who their child has been diagnosed, they've said it's been a key that is unlocking their child, basically, because then they have the management strategies. Their child isn't naughty, they're not a bad parent, it is a condition that can be dealt with really good management and behavioural strategies. So it's not about naming and shaming, it's not about the stigma, it's about supporting diagnosis in the future and supporting that child in the management of their own life. So this is an audit of some medical records at one of the health department hospitals. So it was just around where the Audit C was being recorded. So before the pre-handheld record came in, 40% of midwives were asking about just a general alcohol use question, and 60% weren't. When the handheld came in 2015 or after 2015, then 77% were asking about alcohol and 23% weren't, but only 8% were then recording a score. So then when the Audit C was included in the record, so they didn't go on to do an Audit C. When the Audit C was included in the record, then again, 35% asking about alcohol, 65% not, and again, still low numbers going on to complete the Audit C. So at the present time, it's not really embedded in practice, and what we're hoping with the learning package is that midwives will feel able to do the package and more skilled and have the capacity to go on and do the Audit C. And it is only 3 very quick questions, and at the end of that, once you tally, you have the actual words to say to the lady or to your client. So that, you know, it's not about you making a judgment, it's about you giving the information that they can then take for themselves. So it's about asking, assessing and advising 3 times throughout pregnancy, and as I said, it's non-judgmental, culturally sensitive inquiry, questions to begin history taking. So these are good lead-in questions, basically. Was the pregnancy planned or unplanned? And then that gives an idea of if there may have been drinking during that period before pregnancy was confirmed, then the period of confirmation, the gestation. And a really good way to elicit alcohol intake, which everybody forgets, is were there any special occasions during the period of gestation? And one of our research collaborators on the East Coast found a 20% higher increase in responses when asking about a special occasion. So it's something that we're actually including in all our survey research tools as well. Okay, so this is what women have said about the Audit C. I would be happy if they actually were that invasive about screening, because it is a serious issue. Because if you are drinking 3 days a week, it's 6 drinks at least if it's 2 drinks a day. So that was a very young mother in Armidale, and I must say I was present for all of these focus groups. And the young Armidale women were much more frank about being told not to drink than the women in Attadale or Mount Hawthorn. And if you look at all our research, yes, we have our risk drinkers in our women from low socioeconomic suburbs, but we actually have our regular drinkers in our high income brackets. And this is a mum in Attadale. I don't know anyone who actually pours 1 standard drink when they pour their own wine glass, and that's definitely the case. And then an older mother in Mount Hawthorn says, maybe it should be more of an entering into a discussion like, let's try and work out how much you do drink on those days. So it doesn't have to be confrontational, and as you've seen, and as you probably have heard of the Women Want to Know education program run by FAIR. So women do want to know, and they want to be asked and educated. Okay, I'm going to pause there and ask if anyone's got any questions before I move on to some breastfeeding, and then I can talk about Bankshire as well.
They're the person to go to. I'm sorry I can't state the entire PC. Thank you.
It's about to do here, like more visual and like.
Okay, does anyone have a question? We might just see if someone can raise their hand and then we can choose who goes first. Sorry, I'm new to this. So does anyone have any questions? And believe me, all questions are good questions.
Unmuted.
Okay, so that looks like Geraldton has a question. Geraldton, do you want to go ahead?
Hi, with you were saying the learning package, is that just the alcohol and breastfeeding online learning package, or is there a learning package specifically around the audit?
No, it's specific. It's not. There's a small part about breastfeeding, but it is predominantly focused on the Audit C.
Okay. What's the learning package called?
It's called the Audit C learning package. We didn't want to complicate it.
Okay, cool, great.
Yeah. If we don't have any, do we have any questions from any of the sites? Is that, I'm not sure if that's saying no. I can.
Yeah, I'm not sure they're putting their hand up.
Someone's putting their hand up. We're just going to say, please ask your question.
And coming up. Is it coming up? No, it's the hand around chocolate.
No? Okay. We've got a question. We've got two questions in the room, actually. Yes, Terry.
It's Terry here. Just in relation to the three questions, when we've just been reviewing the Audit C tool, there's been discussions at a national level around the collection of data in relation to alcohol intake during pregnancy. So you may all be aware that the questions that you fill out when you fill out your notification of case attended are part of a minimum mandatory data set, national data set. So across all the jurisdictions, they have agreed that that information, or a core set of that information, is what needs to be completed so that we can have national data around that. The use of alcohol is going to be added to the data set. So there's a group of very wise people who come together to determine what that is going to include and what the questions are going to look like. What they have agreed is that that information will need to be provided on 2 occasions during the pregnancy. So when you actually fill out your NOPA, you will need to put in 2 amounts of alcohol, or alcohol collection, pre-20 weeks and post-20 weeks. Now that won't be happening, I suspect, until next year or maybe even the second half. And obviously you'll get education when that comes. But when you look at the learning package and it says twice instead of 3, that's why. Because we knew that the 2-time collection was coming and we didn't want you to be confused by learning all about 3 questions 3 times and then get advice that you were going to have to collect it twice. So that will be coming, and obviously there'll be a notification from the Department of Health, the Maternal and Child Health section, when that collection becomes mandated. But it is coming, and that's, because it's such an important issue.
Does anyone have any questions around that? No? Okay, we did have another question in the room.
It's Chris here, with the obstetrician.
Sorry, Chris.
I am extremely embarrassed as an obstetrician to hear my fellow colleagues saying that they don't believe in this alcohol syndrome. And there's 2 things I'd perhaps like to share with you. One was when I went to school, there was a family who's in Wales called the Evanses. The Evanses had thin upper lips because we used to take the mick out of them the way they looked. They had absent philtrum and they were always in trouble. When I became a barman at 16 years of age in one of the local pubs, their parents were in there every night drunk as skunks. And that was the first time. Then I went to university and put the fetal alcohol spectrum disorder and that family together. But the way that I asked the question, and I think this might help you on this one, on the previous slide, is I ask about their partner's alcohol intake as a way of entering into what their alcohol intake is. Because that often takes the focus away from the patient. They're not defensive. And what I often say to them is, oh, how's your partner adapting to the pregnancy? Oh, yeah. And obviously, alcohol consumption sometimes goes down, goes up. What's happening there, with your partner? And it's a good way of starting things off and very non-confrontational. But it is so important, and I'm utterly embarrassed to hear what my fellow colleagues are doing. I'm sure it's going to get better, though.
Does anyone have any questions around that? I'm just going to digress for a little bit, around based on what Chris has said about the Evanses were always in trouble. So tomorrow in the paper will be the publication of our results from the Banksia Hill Detention Centre, and that is purely a prevalence study. So we had a team of clinicians, we had an OT, occupational therapist, we might just get you to mute again if you haven't, occupational therapist, speech pathologist, neuropsych, and the paediatrician go into Banksia Hill.
Participants are now muted.
Go into Banksia Hill Detention Centre, which if you don't know is our only youth detention centre in the state, just to do the prevalence of FASD. Now, you can imagine the ethics associated with that and the resistance of working with the justice system. But, it almost brings me to tears because 1 in 3 of those children had a diagnosis of FASD and 9 out of 10 of them had a neurodevelopmental disorder that had never been picked up at school, so through the education system, through the health system, or in the justice system, and most of them had multiple contact with the justice system. So our Aboriginal researcher has said, and I'm sure it'll be in the news tomorrow, that the system is failing these children, and that's purely because no one has diagnosed them and basically cut them free from this perpetual return to detention, basically, or to bad behaviour. Because, so for example, the project officer who had the job of contacting the legal guardian or the parents she tried in terms to confirm alcohol intake, tells the story of one young boy being released, being told to go out the front, the bus will be there soon. Bus didn't come, didn't know which bus to catch anyway, wasn't really told, so just stole a car from the car park. So if you don't give these children management strategies, they just rely on what they know, and what they know isn't right because they don't know that either. So diagnosis really is the key that is going to help them work the system better so that they're not always ending up in detention. So it is a great study. It's the highest rates in the world, which is nothing to be proud of at all. And unfortunately, around 80% of the children are Indigenous. So, but that's only because those children are being diagnosed. There will be children who are non-Aboriginal who have the condition, but it's the stigma around getting a diagnosis is not, it is too real, and therefore those children won't be diagnosed. So it's important not to differentiate between the women you see, because all women in our society are drinkers, basically. And this will help their children, which will ultimately help them. So I don't know if anyone's got any questions there. I think someone has. Is that Halls Creek? Is that a question?
You're talking about being a diagnosis, but FASD isn't actually a diagnosis in the diagnostic manual. So if we're diagnosing these children with it, is there something being done so that they can then actually get support from school and funding because they do have a disability?
Yep. So that's completely right, and so this is part of the battle of diagnosing FASD. That then you open these people up to not being able to access services. So our clinicians are very, clever in the system, is that they will include in the diagnosis the neurodevelopmental impairments that need support. So they write them out very clearly so that assistance can be forthcoming. One of our consumer representatives has 2 children, foster children, well, not foster anymore, he's adopted them, and he has been a champion in paving the way for how to get this support as well. So, and we're really working with him so that everyone's entitled to the support. And we learn lots of lessons from children, parents with autism, because they are really amazing advocates for support for their children, and that's where we have to learn from, regardless of how the condition arose, that we want the same model of support for children with FASD. Does anyone have any other questions about FASD before I move on, or the Banksia study? But do have a look tomorrow at the paper and watch the news. No? And hands up if you've got a question, then we just know who's interested. No, that's not anyone, is it? No? Okay. So just to recap, as Terry said, there will be questions that will be mandatory. At the moment, that's all at a Commonwealth level, and we're really looking forward to all the reporting twice during pregnancy becoming mandatory. And this what will happen, it'll become part of looking at the readiness for school, and all those systems will be integrated, and that's the great thing about the world that we live in, that we can integrate those systems. Okay, I'm just going to ask you to put your mics back on mute again if you're not asking a question. Okay, so I have worked in the area of alcohol and lactation.
All participants are now muted.
I did my PhD study in this, and basically what I didn't find these physiological effects, but basically if a mum is drinking and breastfeeding, they don't experience the letdown effect because of the oxytocin is inhibited, and basically the baby will suckle but they won't get as much breast milk, so you get a hungry, cranky baby. They have disrupted sleep-wake patternings. If you think about, if you've had a few drinks, you go to sleep quick, but sometime during the night you'll wake up with thirst or the room spinning. That also happens to a little bubby. And what often happens is the mum goes, oh, I've not got enough milk. They're not getting enough milk. They're always cranky, and so they often will introduce formula. And there's been some evidence, but it's not been repeated, that with chronic intake, the children have a deficit in motor development. So basically, you get a child that looks like that. And no, he didn't need his frenulum snipped. I don't know if anyone's reading the media at the moment. I worked to develop the guidelines around drinking alcohol during lactation. So as I said before, the guidelines, not drinking is the safest option. But it's all about timing, and I looked at an algorithm for timing, and then that was converted to what we know now as the FeedSafe app. And so the FeedSafe app has been supported by the Australian Breastfeeding Association, and basically you put your height and weight in and how many drinks you've had, and at times the period when your alcohol will be free of breast milk. Now, some alcohol in the breast milk is fine. It's actually better than introducing formula if a mother isn't formula feeding, but chronically drinking and introducing alcohol into the baby is not ideal. And I'll just let you know that the app exceeded all analytic outcomes. I think we set a target of 2,000 downloads in the first year, and we had 3,000 in the first month. And even till today, it's used on average 800 times a day, with more times during Melbourne Cup Day and New Year's Eve. So it just keeps on keeping on. We have a lot of information on our website, and we actually have another website which has even more information on which this website is mainly geared to the public, but if you go to a website called, it's called FASD Hub, so that's FASDHUB.org.au. There is a plethora of information for health professionals, researchers and families living with FASD as well. And there's lots of research papers and projects that are underway. But really that's all I've got to say today. I mean, I could talk ad nauseum about those topics, but I'd really like to hear your questions or concerns or just observations that people have out in the regions, because I think out in the regions, you know, it's something that alcohol intake is just as prevalent as here in the city. So does anyone have anything they would like to contribute? It doesn't have to be a question, it can be an observation. We just need a hand up. So, oh, we've got Kalgoorlie. Yep, just go for it, Kalgoorlie.
All participants are now unmuted.
Can you hear me okay?
Yep.
Okay, just a quick question. Obviously these juveniles have been diagnosed now, but what is the earliest age that you can actually make a diagnosis of FASD?
That's a really good question. So we say at school age you can start to make a diagnosis of FASD. It can't be complete, but you can start to get an idea. So usually around when that readiness to school, but once they actually start learning proper school things, so like reading and writing, and that's usually around age 6. So it can be quite early, but we do have some work being done across the FASD and autism team about earlier diagnosis and how that would look, because at the moment we have this you know, barrage of testing and physical and mental assessments, and for a young 18-month-old, which is actually the ideal age when you want to get in there, that's not appropriate. And it's not only is it not appropriate, you can't actually do that assessment then because they haven't learnt red and blue and square peg, round peg, or how to hold a pencil. So this is where a lot of energy is being invested now on early diagnosis. But again, it would need people coming forward to have their child diagnosed, and often it's, in the cases that we see, it's the foster parents who come forward to ask for the diagnosis because their child is quite different from the other children that their biological children. Yeah. So that's a really good question. Does anyone else have a question there? Is that Geraldton? I can see people moving in and out. No? No? Are there any other questions? No? Did anyone else want to contribute anything? No? I don't think so.
No? So can I just thank Roslyn, that I know a lot about it, having looked at the Audit C package over and over and over again, but that's amazing. It's great to have people that, you know, they've probably got a really good understanding from all the work that's been done up there, so lovely of them to come and join us. If nobody has anything else that they would like to add, thank you very much for your time and participation, and we'll send Roz's presentation around. I'll probably look to the regional centres if I haven't got a contact to get it to somebody relevant at the smaller sites, and I'll probably go through the midwifery managers